So, dear colleagues, the International Menopause Society would like to welcome you to our webinar. But first, I'd like to just tell you the information that this webinar has been supported by an unrestricted educational grant from Besant's Healthcare. And Besant's Healthcare had no role in the selection of topics or speakers and has not vetted or reviewed the content of the speakers' presentations. So I'd like to introduce briefly myself. My name is Ludwig Kiesel. I was a former chair in Germany at the University of Münster. And I have the great pleasure to welcome you to our webinar entitled Update on New Blood Tests for the Early Diagnosis of Cancer. This is a really hot topic, and almost every week some new publications. And we have the pleasure to have two outstanding speakers who will introduce you to this topic and give some update on the new developments. So the two speakers will give the lecture kind of together. And so I will introduce both of them just now. First is Dr. Lisa Larkin, and she will give a lecture on the general screening approaches. She is a board-certified internist and women's health and menopause expert with over 30 years of experience in clinical practice and education innovation. She's the founder and CEO of Miss Medicine, which is a company working to improve the care of women across the US through the creation of a national network of expert women's health clinicians. She is also founder and executive director of the Medicine, a nonprofit on a mission to improve the care of women through education and empowerment of women and the clinicians caring for them. Dr. Larkin is on the board of trustees of the Menopause Society in the US, serving as scientific program chair in 2023 and president in 2024. Outstanding expert, and I'm very delighted to have her. And she's joined by Dr. Candace Westgate. She will update us on the newer development in these screening approaches. She's a board-certified obstetrician and gynecologist with specialized expertise in cancer risk assessment, menopause cares, and personalized preventive medicine. She earned her Master of Public Health from Tulane, focusing on maternal and child health, and completed her medical degree in Kirksville College. OBGYN residency training was completed in Georgetown, and she holds advanced certification in advanced laparoscopy, menopause management, and genomic counseling through ACOG, and which is ACOG. So I'm delighted that both of them will have their lecture together, and I would like to invite the two speakers to give us their lecture, which we will discuss later after the lecture. Thanks very much for coming.
Thank you so much. So let me share my slides. Okay, can everyone see the slides okay?
Yes.
Well, first of all, thank you so much for the invitation to speak to all of you today. This is a topic that really is very timely, and the science around these new early detection blood tests are moving very, very quickly in the United States and globally. And I'm excited to have the opportunity to talk to you today with my esteemed colleague, Dr. Candace Westgate. So these are both of our disclosures. I will set the stage just to say that we're going to, Dr. Westgate and I are going to tag team. So I'm going to do the beginning of the presentation. She's going to do the middle section. I'll do a little bit about implementation in practice, and then we're going to do cases. And we would love as much audience participation as you would like when we get to the cases. So our objectives today, we're going to talk about current cancer screening guidelines, the limitation of those guidelines, and barriers to implementation. We're going to talk about the rationale for thinking about a new cancer screening paradigm and the evidence supporting the value of multi-cancer early detection blood tests, MCED blood tests as an adjunct to current screening efforts. We're going to talk about the landscape and where this is moving very quickly. And then, as I said at the end, we're going to talk about how to approach patients in clinical practice, and how you might incorporate this testing into your own practice if it's available in the country where you are. So I'm going to start with the current landscape. And I want to, before I start, just tell you that I understand that this is a global organization, and I want to apologize up front that I am going to give some global statistics, but a lot of what I'm talking about is US statistics and an approach in the US. And again, not trying to make this too US centric, but you'll see as we're talking, there's a reason that how we're thinking about this, we're using US data. And so this was the easiest way to present this information. But across every country globally, the global cancer burden is very, very high. You can see globally, there's 20 million plus new cases of cancer a year, almost 10,000 deaths. 90% of these are linked to environmental and lifestyle factors, not genetics. Interestingly, Australia has the highest incidence of cancer per 100,000 people out of any country in the world. You can see that the projections are really quite dismal in terms of the growth of incidence of cancer and cancer-related deaths going forward globally. And so this is really a very timely topic to think about. How can we do better at, I would say, prevention, but also early cancer detection? So again, not to be too US focused, but we're going to talk a little bit about this. This is US cancer incidence. In the United States, we hear a lot about the fact that cardiovascular disease is the leading cause of death. But I want to just point out cancer incidence and cancer death is very, very high in the United States. 850,000+ men per year, 800,000 women, 2 million new cancer cases per year, 5,500 new cases per day. The incidence in individuals over, and this is an important number for the rest of the talk to remember, is about 1% in individuals over the age of 50. 1 in 2 men will develop cancer, 1 in 3 women will develop cancer, and 1 in 5 people will die related to cancer. So obviously in men, the highest prevalence cancers are prostate and lung. In women, it's breast and lung. And what we know is these cancers lead to very high mortality, 600,000 cancer deaths per year in the United States. Top in men is lung, prostate, and colorectal, and lung, breast, and pancreas in women. And what we know is that the majority of cancer deaths are related to cancers that unfortunately we don't have screening for. So this is really the opportunity for how can we do something to detect A, cancers earlier, and B, all of those cancers that we don't have screening guidelines for. And what of course we know is that cancer is not one homogeneous disease. It's very heterogeneous depending on the site of origin and the tumor biology itself. And so one of the reasons we don't have screening for all types of cancer is A, the way that they present, but also their rate of cancer growth and tumor shedding. And so again, slower growing cancers, we have more of an opportunity for early detection. Rapidly growing cancers, we really don't. And this is why late stage diagnosis of rapidly growing cancers is really part of the reason that morbidity is so high and mortality is so high. So what do we know is that age is the biggest risk factor for cancer. Again, we said environmental factors and lifestyle factors, including obesity, really play into that as well. But age is still the strongest risk factor. And you can see by that very accelerating curve that right at age 50, it spikes. So the average rate is 13 times higher in individuals over age 50 compared to under age 50. And the risk varies 2,000 times across the lifespan from low to high. Risk factors, of course, include lifestyle factors, including smoking, obesity, and then genetics related to family and a family history of cancer, and then prior cancer exposure is associated with secondary cancers as well. And what do we know is unfortunately only 1 in 4 cancers are routinely screened for, right? 71% of cancer mortality deaths are related to cancers that we're not screening for. And so what we know is individuals are more likely to diagnose with a cancer that lacks a screening test than to be diagnosed with a cancer that's detected through our current screening approach, which again just leaves this space wide open for how can we do a better job at detecting cancers earlier and detecting cancers that we don't have adequate screening for. And why is this so important? Well, we just talked mortality of cancers is really high, but what you can see is if you look at the cancers that have U.S. Preventative Services Task Force guidelines, the vast majority of ones are diagnosed later and don't have screening guidelines. So this is really important, again, for how can we detect these more aggressive cancers that we don't have screening for earlier. And we know that late stage cancer has higher mortality. It's pretty obvious, right? If you look at 5-year cancer specific mortality for any cancer, late stage diagnosis is associated with worse outcomes. So this goes back to how can we do earlier detection, especially of those more aggressive cancers. So early diagnosis improves survival. The 5-year survival, if you have a cancer of all comers diagnosed at stage 1 or 2, is 89% compared to only 21% if you're diagnosed at stage 3 or stage 4. And current screening guidelines, again, U.S. Preventative Services Task Force screening recommendations in the U.S. And I recognize that these guidelines may be different depending on where you're living, but again, wanted to focus on how we in the U.S. are thinking about this in terms of looking at sensitivity, specificity, positive predictive value of the currently U.S. Preventative Services Task Force screening guidelines. And certainly for cervical cancer, we can see there's grade A data about screening 21 to 65-year-olds every 3 to 5 years. For colorectal cancer, the grade is A for 50 to 65-year-olds and 45 to 50-year-olds, grade C data for above age 75. For breast cancer, grade B recommendation, this was just updated in 2024. Now U.S. Preventative Services Task Force has come in line with starting initiation of screening at age 40, although the guidelines are still inconsistent based on annually or biannually. And I know that there are disparities in breast cancer screening guidelines globally as well. Lung cancer, there are guidelines for screening, grade B guidelines for individuals 50 to 80 who have a 20 pack year smoking or more. And prostate cancer is one of the ones that's kind of all over the map. I think as the internist, we don't love these guidelines because they're grade C, they're 50 to 69-year-olds. We have to have shared decision-making around this, and there is a current update in progress. Now, remember that these guidelines are for population guidelines, and the actual implementation of these may vary depending on family history and specific risk factors or individuals who carry a genetic mutation. And again, what we know is these guidelines only screen for 28% of cancers. Again, I wanted to say the annual cancer incidence in people between the ages of 50 to 79, and I like round numbers, is about 1%, or really it's 1.2%. But you can see that only 28%, 0.3 of the incidence in cancers are associated with cancers that have these guidelines. And you can see in the boxes at the bottom, the other problem is the uptake of U.S. Preventative Services Task Force guidelines by population in the United States, and again, sorry to be US-centric, is really pretty poor, especially for lung cancer screening guidelines. And I want to spend some time briefly just doing Statistics 101, because I will tell you truthfully, I struggle with this every time. I have to really step back and remind myself the difference between sensitivity and specificity. But what we know when we're looking at a test, right, is that you can't have perfect sensitivity and specificity. And as you move up in specificity, you often lose sensitivity and vice versa. But what high sensitivity tests mean is that it reliably detects a condition. It has a high true positive rate and a low false negative rate. Specificity is the true negative rate. So tests with high specificity reliably excludes individuals who don't have the condition. These are high true negative rate and low false positives. So what we're trying to have, of course, is a perfect test. And we don't have any perfect tests, including the current tests that we have already with U.S. Preventative Services Task Force guidelines. So this is the other way that I think about this. And when we come to these MCED tests, I just want to remind you about this as we're thinking about sensitivity, which is the true positive rate, specificity, the true negative rate, and this thing called positive predictive value, which is the probability that a person with a positive test actually has the disease. And what I want to show you is our current screening guidelines. And I think, you know, again, as the internist, I order these screening tests like I'm a little OCD or a lot OCD about making sure that my patients are getting all of these preventative screening tests. But how often is it that I really sit there and talk about the positive predictive value of each of these tests with patients? I don't, frankly, right? Because I'm checking the box saying, okay, you need your mammogram, you need your CT scan, you're a previous smoker. But do I really talk about positive predictive value? And I do a lot in the breast cancer risk assessment and prevention space. And of course, we know breast mammography for screening for breast cancer is not a perfect test, but I just want you to look at the positive predictive value of mammography. And in practice, I see that all the time, right? I get these abnormal mammograms and I have to call patients and say, your mammogram is abnormal. But the positive predictive value of a screening mammogram, the probability that my patient actually has breast cancer from that first screening abnormal mammogram is low. It's 4.4%. And yet we believe in mammography as a good screening test. And I just want to remind you of that as we get into the MCED tests. So I would argue, and again, I talk about this a lot, I'm not only an internist in the women's health space who cares about breast cancer prevention, I'm a breast cancer survivor myself. The positive predictive value of mammography is low, and yet this is a very important test. The chance of a false positive mammogram for that patient who's getting her first mammogram is between 7 and 12%. It varies depending on breast density. 50% of women will have at least one false positive recall over their lifetime. 17% get a false positive short interval follow-up. 11% of people will have a false positive biopsy recommendation. So we're using mammography, but we know that this test, just like any test, is not perfect. And when we also look at uptake, we can see that uptake isn't perfect either, right? There are so many barriers to our patients getting these tests. I mean, it's dismal in terms of how we're doing with lung cancer screening. And even with mammography across the board in the US, we're only at about 78%. And why is it suboptimal? Well, we know 28% of individuals between 50 and 65 aren't up to date with colorectal cancer screening. And I really push my patients, right? Because we know if we can get you screened, you don't have to die of colorectal cancer. And we're still missing all of those patients. We have patients coming in with late stage diagnosis. 24% of women haven't had a mammogram in over 2 years. 27% of women aren't up to date with their PAPs. And 95% of adults who have a smoking history haven't gotten that lung cancer screening. We also know that there's inappropriate application of guidelines, that women over age 75 continue to have mammograms. I can talk to you a lot about that, which is I don't think that purely age-based screening is the right approach to breast health. And I actually do mammograms in appropriate patients, in my opinion, over the age of 75. So I am one of those doctors who's leading into inappropriate screening. And then 65% of women age 30 to 65 are overscreened for cervical cancer. And the barriers, well, low perceived risk of cancer, misinformation, mistrust of the healthcare system, fear of pain, fear of cost, lack of primary care access, can't get to the screening site, no insurance, low income, low health literacy, lack of transportation, lack of paid time off for work. And what we know is that all of these barriers lead to higher mortality when people aren't getting screened. And we know in the US there's terrible disparities in cancer screening based on lack of access to health insurance. You can see across the board, colorectal, cervical, and breast cancer screening is worse in people who don't have insurance, no surprise. And then based on household income and education, less education, people who don't have adequate income, who are below the poverty threshold, have lower rates of screening. And again, this disadvantages our minority and disadvantaged populations. And there's disparities in cancer mortality. Again, I'm not sure you can read all of this, but you can see that the trends between 2000 and 2020 in terms of overall mortality across all races and ethnicities has gone down, which is great. What is still there, though, is there's clear disparity in cancer mortality that persists. It's narrowing, but overall, African Americans continue to have the highest cancer mortality. And again, we have to do better with screening and early detection in all our populations. What we know is we could prevent deaths if we did better with getting even just our US Preventative Services Task Force implementation up to 100%, right? And this still doesn't take into consideration all the cancers that we are diagnosing that don't have US Preventative Services Task Force guidelines. And what are the challenges? I mean, again, the way that we're doing tests right now has huge economic cost burden, only screening for 5 cancers. I showed you the data about positive predictive value of what we're doing is relatively low. We have high false positive rates. This leads to lots of testing. I mean, breast cancer, I just gave you the example. We're doing lots of additional imaging. We're doing lots of unnecessary biopsies. We know that overdiagnosis can occur. The current screening approaches are invasive, right? Colonoscopy is invasive, time consuming, associated with risks, and are expensive. And we know that adherence to all of these screening tests is suboptimal, especially with our minority and disadvantaged populations. And with that, I'm going to turn it over to Dr. Westgate. And Dr. Westgate, you just tell me when you want me to advance slides.
Thank you so much, Lisa. And good morning from the US. Good afternoon to everyone in Europe. It's a real honor to be here today and excited to talk to you a little bit more about the future, a new cancer screening paradigm with blood-based multi-cancer early detection testing. Next slide. So why do we need a new paradigm? Lisa touched on this earlier, but want to really highlight this article from Cancer Cell that came out just recently, showing that of women going in for breast cancer screening, right there and being diagnosed with breast cancer, there are actually a 3 times higher incidence rate of having a different cancer at that time of screening for that breast cancer. People going in for colorectal cancer screening, right? There's actually a 12% higher incidence of having a different cancer, not colon cancer, when they're going in for that individual cancer screening. So we need to do something different than screening an individual multiple times for individual cancers. We need to look at a different paradigm where we're screening one individual for multiple cancers at the same time with one test. Next slide. And why is this? And Lisa harped on this, but I wanted to put this in perspective. So take a look at a 50-year-old female, a 60-year-old female coming in to her doctor's office. She's a smoker. So based on age-appropriate as well as risk factor-appropriate cancer screenings, she would cumulatively have a 43% false positive rate if she were to get a low-dose CT scan, as well as the cervical cancer screening that was due that year, as well as her colon cancer screening and her mammogram. Right, so with these single cancer screenings and their low positive predictive value, their high false positive rates, cumulatively, this will mean 43% false positive rate. Let's take a look at a man, also at the age of 60, who's a smoker. There's 3 different cancers that he would be appropriate for screening for, and that cumulative false positive rate is around 31%. So high sensitivity, low specificity, low positive predictive value. We can't have another cancer screening that continues to add to this. Hence the paradigm shift of looking for something different. Next slide. All right, so what is the criteria that we need to be thinking of as we're evaluating these MSAT tests and whether they are a good tool for us to be using in the general population? So as you can see this diagram on the right-hand side, we need to balance that sensitivity and specificity argument, as well as really focus on that positive predictive value of the test. So with our single organ cancer screenings, as we spoke about earlier, high sensitivity is chosen over moderate specificity. But with our MSAT tests, we're looking for high specificity, moderate sensitivity, and obviously this is all determined by the aggregate prevalence of the cancer incidence in that population. We're also looking for a test that can help us with the diagnostic odyssey. So does the test give a cancer signal of origin report so that we know where to go looking? Remember, these MSAT tests are screening tests. Yes or no, there's a cancer signal identified, but then what and where do we need to go to next for that diagnostic workup? So does this test predict a cancer signal of origin? The test should also be a test that does not overdiagnose those indolent cancers. And we all know the lessons that I've learned with our prostate cancer screening in the multiple years prior of overdiagnosing indolent cancers that wouldn't kill an individual, but did significantly more harm with all of the interventions that were done, right? To make a dent in cancer and our fight against cancer and early cancer, we need to find a retrospective way to validate these cancer screening tests, because otherwise we're going to be waiting for 10 years or 20 years before we get that outcomes data that we need. And it needs to be cost effective and available to all. Next slide. All right, so the goals, again, of this new cancer paradigm is to shift cancer detection to an earlier stage, to hopefully increase the treatability as well as reduce the mortality, to provide screening for cancers without previous rigorous screening options, to increase the rate of screening in our patients, while we're also focusing on reducing the cost associated and the burden associated with it. To be successful, we need to focus on that low false positive rate, localize the cancer with high accuracy, limit that overdiagnosis, and deliver benefits to patients beyond being non-invasive, such as increasing the quality of adjusted life years for patients as well. Next slide. Okay, so the opportunity here is not to do away with our current single cancer screenings, because they do have significant importance, and we know the benefits and the outcomes of them, and that's been proven over and over again. But instead, the opportunity here is to add an MCED test in addition to our current single cancer screenings, and by combining them together, there's high sensitivity that's associated with our standard USPSTF screenings for those high prevalence for cancers with MCEDs. And then with the MCEDs for our low prevalence cancers, we're not going to be getting too many false positives. Again, this is not to replace our current cancer screenings, but the opportunity here is to add to what we've already got going on. Next slide. There is a study that has taken a look at model data. Obviously, we don't have real world data in this space yet. Looking at the SEER registry, and what is the potential opportunity for this MCED technology. And this is by Hubble et al. In Cancer Epidemiology. And it showed that by adding the MCED technology to our current cancer screening, we can reduce late-stage cancer incidence by 78%, reduce 5-year mortality, cancer mortality by 39%, an absolute reduction of 26% of cancer-related deaths. That's pretty impressive. Next slide. Okay, so let's get into the nitty-gritty and some of the science behind these tests and what multi-cancer early detection blood-based testing is. So it's a liquid biopsy, and it's taking a look at cell-free DNA markers. All right, so let's back up a little bit. In the schematic, you can see here in the blue would be normal cells, and in the browny gray would be the cancer cells. So as the tumor grows, an apoptosis occurs, and it's replaced by new tumor cells, obviously. Well, these dead cells then release their cell contents, which includes DNA and other protein markers and other factors into the bloodstream. These DNA fragments have chromosomal alterations on them, they have mutations, they have DNA methylation patterns, and all of these things create a very specific tumor fingerprint. This fingerprint then identifies cell-free DNA as well as the site of origin based on methylation patterns from embryological changes. The quantity of this DNA then varies among individuals, and it also varies among tumors as well as locations. So let's think of the prostate, for example. It's got a thick capsule around it. A lot of prostate cancers are slow growing. And so not a lot of this free-floating cell-free DNA gets into the bloodstream where we're doing our biopsy, right? So we don't pick up, these kind of tests don't pick up certain cancers very well. Based on the blood-brain barrier, these kind of MCED tests and liquid biopsy tests don't pick up brain cancer very well. But if the cancer is fast growing, aggressive, is shedding a lot of its cell contents, then a lot easier to find in a liquid biopsy. Next slide. So here's a schematic just showing some of the changes that can be seen within that cell-free DNA. So there's obviously mutations within the double helix, chromosomal alterations, and then DNA methylation-based patterns. And so keep these in mind as we take a look at some of the tests out there and the different mechanisms of action and how are they finding these alterations and identifying these tumor cells. Next slide. So a very, very busy slide and a very, very exciting slide. to show the huge opportunity and multitude of companies out there that are very interested in this kind of liquid biopsy. Now, there are companies out there, as you can see at the bottom of this diagram, that are blood-based tests to identify single cancers. Okay, that's really not what we're focusing on here today, but just wanted to show you where things lie. It's the multi-cancers, and there's a significant amount of them, as you can see there, in development, as well as others that are commercially available. Next slide. So currently within the United States, there are 4 tests that have FDA breakthrough device designation. So instead of spending the next 2 hours nitpicking apart all the different companies and the tests that they're developing, we're going to focus on these 4 right now. So as you can see, the name of the test is at the top. So CancerSeek, Gallery, Oversee, and CanScan. At the bottom is the name of the clinically validated study that developed these tests. So CancerSeek, the DETECT-A study, if you want to take a deeper look. The original version of CancerSeek is able to identify between 8 to 10 different cancers. It looks at 16 different gene mutations within the cell-free DNA, as well as 9 different protein biomarkers in the plasma. And it assesses whether there is a cancer signal present or not. It cannot tell us the cancer signal of origin. Okay. The Gallery test is able to identify over 50 or screen for over 50 different types of cancers. It's looking at hundreds and thousands of different methylation regions within the cell-free DNA. It assesses cancer signal present or not and gives you a cancer signal of origin. So for example, lung or liver or pancreas. The clinically validated study for this test was the CCGA, and additional studies also include the Pathfinder, showing this in a real-world population. The Oversee can screen for 6 different cancers. It looks at deep methylation sequencing, again, assessing whether there is cancer present or not, and it can predict a cancer signal of origin. And the Thunder study is the name of its clinical validation. The CanScan looks at 13 different types of cancers. It uses low-depth whole genome sequencing of the cell-free DNA, and it evaluates the genetics as well as fragmentomic features. And it assesses whether cancer is present or not, as well as predicts the cancer signal of origin. And its validation study is called Decipher-Omnia. Next slide. So how do all of these these multi-cancer early detection blood tests fare? As you can see here, looking at the bottom of the slide, in the pink is where you should focus for right now, showing the sensitivity and specificities of all of these different tests. So the take home here really is that all the tests are focusing on specificity, and you can see a good range of specificity for all of them, which means less sensitivity, and higher specificity, meaning decreased false positive rates. Next slide. What about the cancer signal of origin, and how accurate are these tests in identifying where the cancer is located? Again, for CancerSeek, they do not give a cancer signal of origin, and the workup for these individuals, if they have a cancer signal detected, is to go straight to a PET scan. That's the workflow for CancerSeek. For the other tests that do report a cancer signal of origin, obviously the workup is then tailored towards that cancer signal of origin. So as you can see there with Gallery, about 85% sensitivity in getting the cancer signal right. Oversee is about 83%, and CanScan about 84%. Next slide. How did these tests perform in detecting the different stages of cancer? Okay, so as you can see, CancerSeek is in the dark blue, CanScan is in the light yellow, Gallery in the brownish, and Oversee in the teal color. And as the stage progresses, so does the sensitivity improve of being able to pick up these tests. And from the biology of cancer, as well as the liquid biopsy from a blood test, that only makes sense, right? A faster growing, more aggressive cancer is going to shed more DNA into the bloodstream. And so it's going to be a lot easier to pick up that cancer at a later stage. Next slide. So commercially available here within the United States, currently we have one test called the Gallery test. There is, and currently being studied in over 315,000 individuals in different clinical trials. And right now, their specificity is reported at 99.5%. Their sensitivity is around 51%. But I'm going to dive into that sensitivity in a little bit to show the differences with the different types of cancers. Negative predictive value, 99.4%, and positive predictive value, 44%. So I'm going to pause for a minute, bring you back to Lisa's talk where she was comparing the other cancer screenings that we have, and the mammogram with a positive predictive value of around 4% compared to this multi-cancer early detection blood test positive predictive value being around 44%. All right, next slide. All right, so sensitivity as a whole, or we reported earlier around 51%, right, for the Gallery test. But when we break it down into tests that already have cancer screening, so breast, colon, cervical, and prostate, the sensitivity of the Gallery test was around 33.8%. Okay, so what does that tell me? We cannot get rid, or this test does not replace what we already have with our current cancer screening tests. For those cancers without a current cancer screening recommendation, the sensitivity of those cancers when we broke the results up was around 63.8%. And the sensitivity was over 80% for pancreas, ovarian, esophageal, and those unknown primary dilemma kind of cancers. So again, those more aggressive, faster growing tumors, the test picks it up much better. For those indolent, slower growing kind of cancers, we're not developing or assessing a test that is catching those unnecessary cancers or those indolent, slow-growing cancers.
Sorry.
All right. So here, sorry, I jumped the gun talking about the positive predictive value. Thank you, Lisa. Again, the Gallery test standing out with a 44% positive predictive value compared to our other cancer screenings, with Cologuard being 4.9, colorectal 2.4, breast cancer only 4.4, and then the range for lung cancer screening. Next step. All right. So as we've discussed previously, this is a very hot topic in the world of cancer screening and early detection. So hot that I wasn't even able to update all of the stuff that came out of ASCO this year, well, just last month, or earlier this month, I should say. But at AACR, so American Association of Cancer Research in 2025, here is a poster presentation that was done at showing real world evidence of that Gallery MCED test, looking at the first 100,000 tests that were ordered in the real world by clinicians out there. So really busy slide, not going to read the majority of it for you. The things I wanted to highlight though, for asymptomatic screeners, there was a 49% of the positive MCED test results led to confirmed cancer diagnosis following a comprehensive cancer workup. So that fits in with the clinically validated studies for this test, that showed a PPV of 44%. Here in the real world, we're showing a PPV of around 49% in this cohort. However, for those individuals that actually got this test that had some cancer symptoms, and people are always going to sneak in with that, even though that is not the indication for this test, the positive predictive value for this test on those that were symptomatic was around 75%. And that is similar to the Simplify study, which was done in Britain, that took a look at those symptomatic patients coming in to the ER, I do believe it was, getting this kind of Gallery test, and then being able to move them into the right place within the NHS for their follow-up and continued diagnosis. And there, the positive predictive value in the Simplify test was close to 79%, I do believe. So collectively, this real-world experience underscores the potential of MCED testing to broaden the spectrum of cancer detection earlier than the onset of symptoms, while maintaining a low false positive rate when integrated with existing recommended screening protocols in clinical practice. Next slide. So what do patients think about this? So I want to take us back to what patients think about cancer screenings in general. So here we have some data that showed that for patients, anxiety and worry are the highest prior to hearing the results and after hearing an indeterminate or a positive results that would require further testing. That only makes good sense. Negative psychological effects did not last very long, even in those with indeterminate or false positive results. And individuals with higher cancer risk have higher levels of distress and more anxiety throughout the screening process. So this is where we live already with our current cancer screenings. Next stage. So the Gallery Pathfinder study looked at this question as well. And so it was patient-reported outcomes assessments completed before they got an MSAT test, after receiving an MSAT test, and then at the end of the study. And the results in regards to patient satisfaction showed that patients with true positive results had a 92% satisfaction, and patients with a false positive results, their satisfaction wasn't as high, 82%, as you can expect. From anxiety, there was a higher level of anxiety following a positive test result compared to a negative test result, and we know that to be true already. And anxiety results returned to pre-MSAT test levels within 12 months. So I think this goes to show that it fits in with what patients are already experiencing with our current accepted cancer screenings. Next slide. So let's talk a little bit about some of the upcoming studies, and there are many of them, so I've chosen to highlight some of the big ones. The National Cancer Institute is starting a study called the Vanguard study, and the goal is to enroll up to 24,000 individuals between the ages of 45 and 75 to study and offer them MSAT screening and study it further. The REACH study is a real-world study of the Gallery MSAT tests. The goal is to enroll 50,000 Medicare beneficiaries and compare those to standard of care cancer screenings so that we can determine outcomes from this. So currently, REACH and Vanguard are in the enrollment phase. A very exciting study, which we cannot wait for the results to be published, is the NHS Gallery study. 140,000 individuals have already been enrolled, the largest randomized study of an MSAT test in asymptomatic individuals. I'm going to go into a little bit more detail about the NHS Gallery study. Next slide, please. So they're looking at participants aged 50 to 77 across 8 regional cancer alliances in the United Kingdom. It began in 2021, 3 annual blood draws per participant, and ongoing and follow-up through 2025. Results are expected to be reported in 2026, so we don't have to wait too much longer for these results. The primary objective of the study was to assess whether adding the Gallery test to standard screening reduces late-stage cancer diagnosis compared to usual care. Participants with a cancer signal detected undergo standardized referral into the NHS urgent suspected cancer pathways. And the trial implemented centralized e-referrals integrated into existing trust workflows to help minimize the burden on the primary care providers. So taking the workup of these patients off the primary care providers into a specialty clinic. So we're anxiously awaiting the results of the study. Next slide.
Okay.
Back to you, Lisa.
Thank you. All right, we're going to talk a little bit about potentially how you would implement this type of testing in your clinical practice. So obviously MSAT tests are blood sample, right? We draw blood labs on our patients, and the goal is to detect cancers that are rapidly growing that we don't have screening for, to try to detect them early. The hope with the test is to have a cancer signal of origin so we can quickly and easily and cost effectively identify the site of origin. The studies, the tests, as you heard, are going through population scale clinical validation. And the goal, again, is to have high specificity for these tests. So we're not doing a lot of blood tests on millions and millions of people that are generating high false positive rates. And the goal of the test, again, is how do you implement these alongside U.S. Preventative Services Task Force guidelines? So who's the ideal patient? Remember, in the US right now, we're really talking about Gallery. That's the only test that's commercially available. It is a test that I offer in my practice to my patients. So in the Q&A, if you have questions about, I took out the slide just in the interest of time about kind of what the data is from my own personal practice, but I'm going to explain that this is how Gallery is being implemented in practices and by clinicians and in health systems in general, because we see that very big spike in cancer incidence in individuals over age 50. That tends to be the age at which we start, although like anything in medicine, nothing is hard and fast. There are other high-risk features that we consider with patients, right? Smokers, do they have strong family history of cancer and early cancer? Do they carry a hereditary cancer genetic mutation? Do they have a prior history of cancer and are at risk for secondary cancers? Are they pediatric cancer survivors? Are they chronically immunosuppressed? Other patients, and this is something that gets a lot, and of course, I think everyone on this probably is aware, there is some pushback about these tests right now. They don't have US Preventative Services Task Force recommendations or guidelines. There's also concern about disparities in implementation. But other people are coming in asking about this. Social media has certainly raised awareness, and there's certainly the menopause is having a moment, but longevity and wellness is having a moment too. So a lot of patients worried well are coming in. But what about other patients who have the dwindles, as we call it in internal medicine, non-specific findings, weight loss, they're elderly, inconclusive findings? Is there a role for this test in those patients as well? I want to just explain how I talk about the statistics with my patients, and I do this in the menopause and hormone therapy space too, right? Patients, we need to make it kind of simple for them. Now, recognize, as I said, I don't do this when I'm talking about ordering their mammogram, and maybe we should, but because this test doesn't have US Preventative Services Task Force recommendations, and because I am offering it to patients, I really want to make sure that they are fully informed and that this is shared decision-making about doing this test, because not only does it cost quite a bit of money, it's about $1,000, just under $1,000 in the US, we have to talk about the data, right? And I can tell you on social media, there are some groups that really push back. I saw one post that said, if your doctor's ordering Gallery tests, we think that you should find another doctor. And I obviously order them, so I hope that that's not the way that most people feel. But this is what I talk to patients about, because I do think they need to be informed. So if we use that number of a 1% prevalence rate of cancer in individuals over age 50, we would think in 1,000 patients, 10 people would have cancer. If we look at the Gallery test, what we know is that the prevalence rate of a positive Gallery test is about 1% in the population. So 1,000 patients tested, we would get 985 true negative tests. We would likely find 10 positive tests. Of those 10 positive tests, 5 of them, again, if we're using round numbers, 5 would be true positives, 5 would be false positives, and we would miss 5 people with cancer with a false negative test. But 985 patients out of the 1,000 that you've tested have a true negative test, which goes along with the very high specificity rate of the test. So again, when I'm ordering this test on a patient, I tell them, it's a low possibility that you're going to have a positive test, about 1%, and it's actually less in my own personal practice, I believe, because I have a lower social determinants of health and lower obesity and lower risk factors for cancer. So I believe the prevalence is under 1%. But in general population, 1% cancer rate, 10 out of 1,000 tests would be positive. 5 of those would be true positive, 5 false positive. And so for patients, if they get a positive test, I want to tell them this up front, because just like with getting a positive mammogram, what a positive Gallery test means is it's not 100% that you have cancer and we have to do more testing, but the cancer signal of origin, because that's reported with the Gallery test, helps me have a very defined workup depending on that cancer site of origin. And again, not to beat a dead horse, although maybe that sounds terrible, that it's a roughly 1 out of 2 of those positive tests is going to be a true positive. I can tell you for the patient where it is a true positive, that's very impactful. And the other thing, remember, compared to mammography, where we're doing a lot of mammography and we're doing a lot of follow-up tests, because the positive predictive value is only about 4%. And so again, how I'm doing it is I'm talking to patients at their annual physical. I'm considering it in individuals over age 50 and very specific younger individuals in our health systems here in Cincinnati, in the high-risk cancer clinics and the genetic clinics, patients that have genetic mutations where we are still doing screening. This can be an adjunct test. Patients who have severe occupational exposures, i.e. firefighters. There's other subpopulations where we might be doing this below age 50. I have a lot of in-office materials. I've personally done some virtual education programs for my patients like this to answer questions. We collect the blood in the office. It takes 10 days to 2 weeks to get the results. And then I am following up with the patients with a phone call with their results. These are what the reports look like. I actually think they're very detailed and very good reports. And just briefly, I know there is some pushback. This was something in OBG management just saying, it's really not prime time. And as I mentioned, there are some physicians who really feel that it isn't ready for prime time. And I understand that. Certainly there are equity issues because this is a costly test that is not covered by commercial insurance or Medicare in the United States now. But again, the way that I'm approaching it in practice, and this may not be right for everyone, is I am trying to provide the patient sitting in front of me with the best possible information I can about what's available for screening, the potential limitations of the test, and then it's through shared decision-making offering it. But again, there may be some of you on the call that really push back on this, and I'm happy to take those questions. So I think the questions are, is this ready for population screening? Do we have data yet that it saves money and can lower the cost per cancer diagnosis? Are we really catching cancer earlier? I think you saw in that, some of the varying tests, are we really going to be able with this to catch stage 1 and stage 2 disease? Can we prove that this is decreasing mortality? And then where I struggle in practice is the target population. Just like I said, which is I'm really in medicine, nothing is one size fits all. So arbitrary things, even in the menopause space, right? Anything, 10 years and, 10 years from your final menstrual period or under age 60, right? Should it be all age 50 and should it be annually for everybody? I don't know that we have that data yet. I think for me in practice, it really varies based on patient and individual risk factors for that patient in terms of age of initiation, when I'm stopping and how frequently I'm doing it. I do think there's a role in hereditary cancer mutation carriers. And I do think there is a role that we are going to find where this can be used in patients who do have symptoms or inconclusive findings on imaging. So again, is the right interval when 1 year? What age should we stop? And then the recommendation right now is that in cancer survivors, so someone like me with a history of breast cancer, if you're beyond 3 years from that primary diagnosis, that you can still consider testing. I can tell you that I don't like that 3 year as an arbitrary number because not all cancer survivors are the same. Not all cancer survivors have the same risk of recurrence. And what we know in some of the real world data from this is we are picking up with Gallery early molecular disease recurrence in some of our breast cancer patients, and we just don't know exactly what to do with that information yet. And so again, should this be a blanket 3 years is the right time to repeat? And then this is the same thing that we struggle with in medicine in the United States about fragmentation of care and who owns this test, who should be doing it. It's the same thing we struggle with in hereditary cancer genetics, who should be doing this, or even in risk assessment and breast cancer prevention and chemo prevention, right? It's like the hot potato. Like in this test, right, this is not really, should not be in the role of the oncologist because these people, this is a screening test. I believe this really should fall into the realm of primary care physicians. But interestingly, in my system in Cincinnati, one of the health systems is broadly rolled this out to their primary care network. I'm still getting patients in practice referred to me from those primary care doctors to have conversations about testing, because again, implementation is not so easy or routine for most primary care doctors who don't know the data very well yet. And then it's management of a positive test, like say the workup is negative, and we'll talk about this in the cancer, in the cases, repeating a test, what's that right interval? What if the second test is negative, the first test is positive, the second test is negative? Should you do a third test? And what about imaging? How regularly you should do that? How confident can you be that if you have what you think is a false positive first test, the second test is negative? Can you be really confident that that was a false positive, or should you be repeating a third and fourth time? So I think there's a bright future for this. I personally really believe that the next 5 to 10 years, we will see broad adoption of this, that the science is really, really the way forward and the future. But there's lots of concerns about reimbursement and equitable adoption, and we need more data. So conclusions. I think this is great technology. We are not going to use it to replace traditional screening for those slow growing cancers where we do have the opportunity to screen with currently US Preventive Services Task Force guidelines. Currently, the MCED Gallery has a positive predictive value of about 40%. And remember, if you're implementing this, that we have to talk to patients about this with all tests. There is not a perfect test out there, that it is a screening test, and there can be false positives and false negatives. Oops, sorry. And we're going to go to clinical cases now. And again, I don't know, Professor Kiesel, if people want to put things in the chat or comments about this while we do the cases, or how you want to do this, but we will start. Candace, I'm going to ask you about this patient.
All right, I'm ready.
This is Olivia. She's 30 and she comes in, she's worried about colorectal cancer. She has a 3rd degree relative with early stage colorectal cancer. She's up to date on her pap smears. And I just threw in the family history, but she has family history negative, we'll say, for colorectal cancer. Is she a good candidate for you to think about doing MCED at this time?
Excellent. So, Lisa, I really like the fact that you brought in family history, right? So, assessing the patient's past and what the family's bringing in to make sure that she's not at high risk from that reason. So, I'm glad that you included that. If she's up to date on all her cancer screenings, no significant family history, the current guidelines say in the USA start at age 45, right? So, are there any other risk factors that I would be considering for her? You know, maybe obesity, lifestyle, but based on what we know about her right now, I would not recommend MCED testing for her. She is too young for this. And the chance of having, and if she did come back with a positive, the likelihood it would be a false positive is higher because of her young age. But here's an amazing opportunity to speak to the patient's anxiety, right? She's really concerned about colorectal cancer, and engaging her in a discussion about, well, what are all the other things that are increasing your risk of colon cancer right now? Diet, exercise, drinking too much alcohol, not, eating a plant-forward whole foods diet, right? Maybe eating too much red meat, processed foods. So really engaging with her to give her tools that she can walk out of your exam room with, feeling empowered, but no, this test is not right for her right now.
Okay.
All right, so I'm going to ask you more about Dave and what you would do in his situation. So Dave is a 67-year-old man with medical history significant for hypertension. He's a former smoker with a 25-pack-year history. He only quit 5 years ago. He is worried about lung cancer, and so he asks if MCED testing is appropriate for him.
So great. So first of all, we know that he meets criteria to have his screening lung CT, and we should absolutely make sure that he is up to date on that, because he's right to be worried about lung cancer. He also is at risk for other cancers, and we need to really, again, step back and make sure that he is up to date on colorectal cancer screening, and that we are having a discussion with him about prostate cancer screening. But we certainly don't want to miss the forest for the trees and have him come in and order an MCED test without making sure that he's up to date on US Preventative Services Task Force guideline recommendation. Now, the truth is, I can tell you that with informed information, like I just went through about how I talk to patients, I would offer MCED testing to Dave. Now, that's in my practice. I have the ability to do it, and I have the time and the interest in this to be able to have the conversation with him about the fact that he could get a false positive test. And he has to be aware of that, just like we know that when we do screening lung CTs, and we see this all the time, particularly in Cincinnati, where we have high prevalence of granulomatous disease, I often get screening CTs back with pulmonary nodules that then we are going through and working up with additional screening, right? So again, no test is perfect. And I can tell you, I would offer MSED for Dave. And I don't know, Candace, if you have any opinion about that or would do it differently.
No, I agree completely. So, based on age alone, he'd meet criteria for being at that increased risk, and to consider MSAID testing. But then in addition to lifestyle and a smoking status, there's the second and third opportunity there to consider MSAID testing, like you said, in addition to all the other appropriate age-based cancer screenings.
And I think we'll do one more. Candace, I'll put this back to you just because it is right on the hour, and I want to make sure, Professor Kiesel, that we can take some questions if that's okay. So this is Lana. She's a 48-year-old breast cancer survivor. She has a history of stage 2 estrogen receptor, progesterone receptor invasive breast cancer. She was diagnosed 5 years ago. She had bilateral mastectomies, chemotherapy, and radiation. She's still on tamoxifen. And is MSED appropriate for Lana? How would you talk to her about this test?
Very good. So again, always start at the beginning. With her young onset breast cancer, I would make sure that she's undergone genetic testing to make sure that we're not missing high risk of ovarian cancer if she's actually a BRCA1 or 2 carrier, for example. Make sure she's up to date on her colon cancer screening as well as her cervical cancer screening. So make sure from a foundational standpoint, we're assessing her true risk and status. But the fact that she's more than 3 years out from her prior cancer and has no evidence of disease at this point in time, she would be an appropriate patient. Even though she's less than 50, we know that cancer survivors are at elevated risk of getting a secondary cancer. So why the 3-year arbitrary time frame, Lisa? So that was based on the CCGA clinical validation studies, and then in Pathfinder as well. So the individuals had to be more than 3 years out of their cancer diagnosis and with no evidence of disease. So it's not to say we can't do this test on someone earlier, but we have no data to be able to interpret that. Is it a recurrence of their cancer? Is it a new cancer, or is it the old cancer, cell-free DNA, that's just hanging around? So that's where the 3-year comes in. Number one, earlier time frame just hasn't been studied yet.
So I will, before we switch off, just push on you a little bit to how you answer questions, because this is a real patient of mine. And in fact, it's actually me with variables changed a little bit, which is the medical oncology world would say absolutely not to do this testing on this patient. And frankly, really pushed back on me that in this patient, you were opening up a can of worms. Now, I will tell you the truth, which is that we know this patient is at risk for secondary malignancies, but we also know that this is an ERPR positive patient, and late recurrences happen not uncommonly in this type of breast cancer patient. And what we know from the real world data is that we are, in some patients, detecting early molecular disease recurrence, that they will go on to have metastatic disease later. The oncology community pushed back on me to say, what are you going to do with the information if it's positive? Because we don't have data that treating that early molecular disease recurrence does anything. I can push back and respond, but I wondered how you would respond to that.
First off, just want to separate the minimal residual disease discussion with this multi-cancer early detection cancer screening. So remember, with this test, the sensitivity is not very high, whereas for a minimal residual disease test, the sensitivity is extremely high. We want to, be able to pick up that recurrence at the very, very earliest. So this test should never be used for that purpose, right? But here's where I would push back on the oncologists, because as we know, an individual just with breast cancer or with one specific cancer is actually at higher risk for developing another cancer. And in my practice and with my former employees, I ran the high risk genetic program for them. And so was able to get 100 patients tested with the Gallery test from Foundation testing, donor testing, and was able to find 6 different cancers in those 100 individuals. Now, these are all high-risk individuals that have a genetic mutation, and only one of the individuals did we find a cancer that was associated with a genetic mutation. All the other cancers that we found were associated with being a human, being a woman, or being a man, right? And it wasn't associated with their BRCA positive or their ATM mutation. So the value that this kind of multi-cancer early detection plays, even in the highest risk group, is the addition to what we're already doing, because of the vast risk associated with multiple cancers, not just that high-risk cancer that we're looking at under a microscope, right, based on their gene positive. So that's my anecdotal and an aha moment for me, is the importance of a multi-cancer screening approach, not just honing in on that person's proposed risk factors, right? Yeah.
Okay, great. Professor Kiesel, would you
Yes.
stop sharing and we can do Q&A for a couple minutes? Is that okay?
Yeah, I hope we have some more minutes for that, because we've got an interesting question. And first of all, I'd like to thank for these wonderful presentations and on this very complex topic. Well, first question by Dr. Thuong from Vietnam. He asked about why Gallery has low sensitivity for cancer with current screening method, such as cervical cancer.
Candace?
I can answer that one as an OBGYN. So as we know, with our current cancer screening for cervical cancer, that is the pap smear, right? And that's screening and helping us find a pre-cancer, right? Not even cervical cancer. And so we do a great job with pap smear testing of even picking up a pre-cancer and treating that so that it doesn't develop and turn into an invasive cancer. Again, the biology associated with cancer, cancer growth, cancer development, cancer spread, with these HPV-related cancers, we know that they are slower growing than some of the other aggressive cancers, and it takes years and years to go from a dysplasia to, to an invasive cancer. So with the Gallery testing, because it is a blood sample, we're not sampling the actual organ or the tissue like what a pap smear would do. It would need to have already been invasive for the Gallery to pick it up, and it would need to be more of a fast-growing, more aggressive cancer. And so what this also shows us is the importance of our current cancer screening playing a very important niche, and then the addition of something not the same as, right? So we want a test that is going to fit a different opportunity in a different niche, not double duty what we're already doing with our current cancer screening.
Yes. We've got 2 questions by Dr. Naftalin regarding, he mentions, says, bravo for doing late cancer testing. The guidelines on breast cancer screening are not correct. And then he adds, the same for late cervical cancer screening, especially for women who have changed partners. So I understand from that, he regards this as a late cancer testing. As you mentioned before, you have screening like cervical, we have quite even precancer lesion. So maybe that's the question. So he thinks the guideline on breast cancer screening are not correct. That's what he mentions.
Well, I'm not exactly sure the question exactly, but let me respond. I mean, I think age-based screening specifically for anything does not allow for nuance of risk factors or, individual risk of the patient. Where I believe for everything we will move towards is much more about guidelines that take risk factors for mammography and other cancers into consideration as we're developing much more precision guidelines that take into consideration genetics, risk factors, SNPs, potentially radiomics from that first mammogram, and then, biomarkers, everything else that we're looking at to have a much more tailored approach to breast cancer screening, because age, although it's a really important risk factor, it's not the only risk factor. And we're over screening low risk people and we're under screening high risk people. And, you know, age just isn't a perfect, age-based screening guidelines are not perfect.
Yes, and there are some questions about the costs. So one question about is, do I have this correct? Test costs $1,000 for 1,000 people or patients, so that's 1 million. For 1 million, we find 2 actionable cancers on which we then spend a good deal more money. Is this reasonable costs? That's one.
Candace, you want to take that? I mean, I can comment too, but you go ahead.
You start, Lisa, and I'll fill in after you.
Well, so absolutely 100%, the cost is not sustainable for population screening. I use the analogy with patients, rightly or wrongly, that, you know, the first cell phone that came out was very expensive and didn't do a very good job. And, you know, very quickly with advances in technology, the price has come down, and what the phone is able to do is dramatically improved. If we look at the cost of genetic testing 10 years ago, I mean, when I had my cancer diagnosis, I paid $4,000 out of pocket for genetic testing. And now a hereditary cancer panel in the US is $250 out of pocket cash. So the cost has come way down. So I am very sensitive to the fact that at almost $1,000 a test right now, that does not make it equitable or available to the vast majority of people. What it's allowing for, in my opinion, right now is collecting more real world data and fueling the science and the research to bring the test down and make the test better so that we will have a better test to implement for population screening in the years to come. But I am very sensitive to the fact that you're right. Now, I can tell you in my own practice, I've had, you know, 1 positive test out of about 280 tests, right? So relatively low, not 1%. And I can tell you that, again, it depends who you're talking to, right? So that's $280,000 for a positive test. For the 1 positive person with the positive test, that's impactful. For the cost is $280,000 for a society population. That's ridiculously costly. For the 1 person where it's positive, it's very impactful. And again, where I've landed in practice is trying to do the best thing for the patient sitting in front of me, which at the moment is not perfect or equitable. And I'm hoping the cost will come down very quickly as new tests come to market and there's competition.
Thanks. Question from Singapore. Is Lucen's test comparable to Gallery test?
I don't, Candace, do you know? I don't know that test in particular. Lucen's
It's spelled Lucen.
I've heard of the company, but I don't know their test. I don't think it's not launched commercially in the US.
Yeah, I don't know. It looks like from the question it's available in Singapore. Is that correct?
Okay.
Yeah, then the question.
Yeah, I would just say to the person with the question, take a look, see how many cancers they're screening for, take a look at their specificity, sensitivity, and positive predictive value, and then what the diagnostic workup is, in addition to what is it in the liquid biopsy that they are evaluating. Is it methylation patterns? Is it DNA alterations? Is it fragmentomics, proteomics? You know, what's their assay?
Okay, then now a different question for the patient, for the breast cancer patients over 3 years who do have a positive test for breast with Gallery. What do the oncologists do if there is no new cancer found? As a breast cancer survivor myself, over 50, I would be very concerned about the uncertainty of management.
So I'll speak to that just as a similar patient. And so, as I kind of alluded to, my oncologist personally was very negative about me doing the test. And I did the test with very clear information about the fact that I might get a positive test with a signal that says breast, without having, and what I know from the limited data is that when we're looking at, as Candace mentioned, when we're looking at tumor-informed molecular disease recurrence testing, that overt metastases generally occur within about 36 months of that positive molecular disease recurrence. In Gallery, I don't have the data. I think some of the patients in the study, when they had the positive MSED test for Gallery, when they did bone scans, PET scans, they did find metastatic disease already on imaging in those particular patients. And so again, my oncologist did push back on me to say, like, what are you going to do for the information? For me personally, it would have been helpful information because I would have modified what I'm still on tamoxifen now. I would switch therapy. I would do something. I would get my life in order. Like for me, I went into doing the test with my eyes open, recognizing that my oncologist didn't want me to do it because she was not sure how we would use that information to change my management. I thought that I had ideas about how I would change my own management and what I would do. So again, it's still a little bit the wild, wild west about this use in breast cancer survivors who have a late recurrence risk, I think. Candace, I don't know if you want to add to that.
Yes, I'm going to take a little different approach because I realized, Lisa, we haven't actually spoken about like the workup and how all of this goes. So if we get a cancer signal detected and the test gives us a cancer signal of origin, we would then work up appropriately based on where the test is telling us the cancer signal is coming from. If a comprehensive diagnostic workup, which could mean blood work, it could mean imaging, it could mean biopsy, if that comes back negative, we can't find anything anywhere. Maybe it includes an endoscopy or a colonoscopy as well, right? And we can't find anything anywhere. The next step in the workup process is 3 months later, the patient gets a free Gallery test for a repeat test. And if that then comes back negative, then that tells us, okay, either that was a false positive initial test, or maybe it was a very early cancer and the immune system did its job, what it's made to do, and it cleared that early cancer. But now the test is negative, so that signal has gone away. All right, if the signal, the second test comes back positive again, then we do the diagnostic workup again. And we've got some interesting data that will be coming out with the Gallery test to show that progression and what percentage is workup and what's the chance of it actually being a true negative if that second Gallery test is negative after initial first positive. So there's a lot more data to come out based on, you know, real world evidence as we're evaluating this test as it progresses. But what we are finding in some instances where that cancer signal remains positive is that this liquid-based testing is finding or picking up a cancer before our imaging or our biopsy is. And I have an exact example of this where 9 months later, and lung cancer was found on a firefighter when previously the imaging hadn't shown anything that was of concern. So we don't take those persistent cancer signal detection positive results lightly at all. We keep looking.
Yeah, I think we got through most of the questions. The other ones are for the organizers. So I think we have had some additional time for questions, and they were very challenging ones. And I think we'll need soon and further updates. And I very much hope we will have new data from all these studies. Actually, one of the patients who were actually the individuals who was participating in the UK actually mentioned that in her point. So we're looking forward to the details of the studies in 226 and a lot of other things you mentioned today. So I would like to thank the two outstanding speakers for summarizing such a really difficult subject with many facets, from medicine to social and economics. And I hope we can update that soon with new data or at other meetings. And IMS will have next year a meeting I will show you later. So I would like to thank also the attendees for challenging us with all these questions, and looking forward to announce further webinars to those who are interested. So just reminding you that the International Menopause Society, IMS, has various topics, and as you see it here, and you can access the website of the society. You can go to all the interesting options you can choose from. And the next slide shows you that if you become a member, what we would like you to become. This is, of course, inclusive, and it's a free 1-year membership for IMS. And there will be also membership being free for the local societies. They are called camps. And there are also monthly events which you can access in a library. So we're very happy if you can go to the website and join the society to make this thing very powerful. And those of you who like to travel to nice places would like to extend our invitation for next year in Rio. And just reminding you, 2026, when new data will come out. I guess like the big tests shown by Dr. Westgate. So hopefully she will be able to present further details. And I think we will be able to discuss many aspects of it, and everybody is invited to go there and listen to our wonderful speakers. Well, thanks very much again for joining us, for the speakers and attendees, and a good day.
Thank you.
Thank you.
Bye-bye.